Oh, wonderful. Thank you so much. Hi, everyone. Thank you for being here today. My name is Merin Shaju. I am a PhD candidate at QUT under the supervision of three wonderful supervisors, Dr. James Hughes, Dr. Audra DeWitt, and Professor Jane Phillips. And I believe a few of them are joining me here today, so thank you. I'm also a registered nurse working in emergency care at Royal Darwin Hospital in the Northern Territory. I would like to thank the QTE Grad School for giving me the opportunity to share both my research and my journey as a non-Indigenous researcher working in Indigenous health. My focus in this presentation is on cross-cultural collaboration and how essential it has been to this project. Please note that throughout this project, I will be respectfully referring to the Aboriginal and Torres Strait Islander population as Indigenous Australians. Before I begin, I would like to acknowledge the Larrakia people as the traditional custodians of the land on which I am presenting from today and where this research is designed to take place. I also acknowledge the Turrbal and Yagara peoples as the traditional owners of the lands on which QT now stands. I pay my respects to their elders, past, present, and emerging, and I extend that respect to all Indigenous peoples joining me here today. I sincerely hope this research honors their stories, strengths, and ongoing connection to country. So in today's presentation, I will begin by outlining the background and context of this research, followed by my personal motivations to pursue a PhD around this topic. I will then introduce the research questions and walk you through how the design has evolved over time through Indigenous community engagement. From there, I will explain the methodology and the frameworks that guide this project. And this includes the Aboriginal Participatory Action Research, Two-Eyed Seeing Framework, and the Social and Emotional Wellbeing Framework. I will then discuss the Indigenous collaboration and engagement strategy, which includes the vital roles played by Indigenous advisors, the project reference group, and the participants themselves. Finally, I will end my presentation with some of the key lessons I have learned about cross-cultural collaboration in Indigenous health research over the past 2 years. So starting off with the background, acute pain is one of the most common reasons people present to the emergency department. Yet the tools we rely on are rooted in a very Western biomedical worldview. And these tools often assume that pain is easily described, measurable, and universally experienced. In my early conversations with community members across Darwin, I found that for many Indigenous peoples, pain is connected to their mind, kinship, spirit, and community. And so when clinicians rely solely on biomedical measures, we risk missing and overlooking the deeper meanings beneath a person's pain. This conference emphasizes the importance of amplifying Indigenous voices, and this research aligns with that by adopting a relational way of listening and learning. It examines how acute pain care can be transformed when Indigenous knowledges and lived experiences shape the direction of this work. So here in the Northern Territory, where Indigenous Australians make up almost 1/3 of the total population, the ED serves people from many different language groups, cultures, and communities. And so in such fast-paced environments, misunderstandings can occur when assessments do not reflect a patient's worldview or communication style. This research responds to this disconnect by exploring how acute pain care can not only be clinically effective, but also meaningful to the patient, grounded in two-way engagement, and ultimately culturally safe. So my motivation for this research began during my early years as an ED nurse. One of my biggest pet peeves was opening a patient's chart and finding that no pain score had been documented for hours, even when the patient had clearly presented with acute pain. If you've ever gone into the ED, you'll probably remember being asked, on a scale of 0 to 10, what would you rate your pain? Over time, I began paying more attention to this question and realized that many patients, especially those of culturally diverse backgrounds, do not respond to this question. When I spoke casually with many of my colleagues, they also agreed to have similar experiences. And due to the pressures of the ED, they often did not follow up or explore this in further. As a result, we often end up with incomplete, inaccurate, or undocumented pain scores. Um, there was one incident that occurred prior to me commencing my PhD, and it's stayed with me throughout this journey. I was caring for a young Aboriginal woman who had presented with acute abdominal pain. She was a very quiet and timid woman, and as part of my nursing assessments, I asked her on a scale of 0 to 10, what would you rate your pain right now? And she responded by saying yes. I repeated the question, and she remained silent. Such interactions are common in ED, so I was about to do what many of us would do in that situation and simply move on with my assessment and either not document a pain score or document exactly what she had said in the pain score box. However, I paused and returned to ask her one more question. I gently asked her, Sister, do you understand the question I just asked you? And her response was simple, no. And so that moment made me realize how easily we can assume that everyone expresses and understands pain according to our current system and its tools. It also showed me how quickly communication can break down when we rely on clinical language and tools that may not reflect someone's worldview. That interaction is one of the reasons I decided to pursue this PhD, and it continues to motivate me today. So there are three pillars or focus areas to this PhD. The first is to understand how Indigenous Australians conceptualize and experience acute pain, including cultural, spiritual, and relational dimensions that fall outside of biomedical models. The second is to understand how ED staff perceive, assess, and respond to Indigenous patients and their acute pain complaints, and what factors help or hinder culturally safe pain care in the ED environment. And the third is how these two perspectives can be brought together through Indigenous methodologies, including two-eyed seeing, to guide a more culturally grounded and meaningful approach to acute pain care in the ED. So in terms of my research design, my original design was very structured, following a mixed method study grounded in documentation, paperwork, and numbers. This plan involved yarning sessions using a structured yarning guide, followed by a retrospective chart audit in the ED. At that stage, I was still struggling with community engagement, and I leaned heavily on methods that felt familiar and safe to me as a clinician. As my engagement with Indigenous community members deepened, it became clear that my initial approach did not reflect Indigenous ways of knowing or sharing. And also the feedback from my confirmation panel, guidance from Indigenous advisors, and my project reference group reshaped the study and made me realize that if this research is truly about experiences, then it needed more dialogue and conversations. Through these collaborations, the study has now evolved into a purely qualitative design. The yarning sessions in phase one now involve storytelling, painting, and visual tools that allow people to express their pain in ways that reflect their own communication preferences. Phase two involves semi-structured interviews with ED healthcare professionals to highlight how clinicians navigate acute pain care in a culturally diverse setting such as the ED. Moving on to methodologies and frameworks. This project is grounded in Aboriginal participatory action research methodology, which ensures that the research is done with Indigenous peoples and not on them. APAR guides how I work through relationships, collaboration, and Indigenous-led decision making. It also ensures that this research is carried out in a way that is relational rather than simply extractive. Um, Two-eyed seeing is a framework that I adopted later on once the study shifted to a purely qualitative design. And it allows Indigenous and Western knowledges to sit alongside one another while recognizing that neither is homogeneous. Western biomedical approaches provide important structure, but they also have its limits, especially when it comes to understanding pain through relational, cultural, and spiritual lenses. So by also drawing on Indigenous ways of knowing, we gain a fuller picture or a clearer picture of acute pain care and can work towards a more meaningful and culturally grounded practice. And finally, the social and emotional well-being framework serves as the analytical lens, helping me understand Indigenous experiences of pain within a holistic worldview, which includes their connections to spirit, mind, kinship, culture, and country. Together, these elements guide how I work, how I see, and how I understand pain in this research. It became very clear to me quite early on in this project that I could not and should not do this research alone, as neither I nor my supervisors identify as Indigenous Australians. Indigenous guidance was essential, not just for cultural safety, but for ensuring that this work was shaped by the people and communities it intended to benefit. To support this, I developed an Indigenous collaboration and engagement strategy, which is grounded in the principles of APAR. This strategy brings together three key groups: Indigenous advisors, a project reference group, and the participants themselves. So, Indigenous advisors were the first people I reached out to in this project. They helped me understand whether this topic was a genuine community priority, and whether my early methods were culturally appropriate. Through conversations with Aboriginal liaison officers and an Indigenous academic, I began to see how acute pain is under-recognized, the cultural barriers to communication in the ED, and the limitations of relying on the numerical pain scale. One of the most influential voices was a Tiwi elder who is also a community leader and ED consumer here in Darwin, who kindly agreed to speak with me. During our conversations, he told stories of his own experiences presenting to ED with acute pain, the cultural elements that are often overlooked in the ED, and the importance of trust and connection in creating a meaningful research process. These early engagements revealed how limited my original design had been and guided me towards the social and emotional well-being framework. Most importantly, they reminded me that Indigenous ways of knowing, being, and doing, as well as their lived experiences, are not just an addition to this research, but essential. The project reference group is a strong six-person group made up of Indigenous and non-Indigenous voices connected to emergency care. We currently have a team of two Aboriginal liaison officers who primarily work in our ED, two Indigenous ED consumers, an Indigenous health researcher, and a non-Indigenous research nurse with ED experience. Their role is to guide this project at every stage and ensure it remains culturally grounded, respectful, and community-led. So we plan on meeting before and after each phase of this research to discuss safe participant recruitment and data collection, as well as to ensure that the data collected is interpreted in an accurate manner. So far, we've had two meetings, and the conversations during these meetings have had transformative impacts on the research design. For example, at our last meeting, the group engaged in a deep conversation into how paperwork can feel overwhelming or unsafe for some participants, which then directed phase one into a more interactive yarning design. With their guidance, we have decided to give participants the opportunity to paint their perception of pain, and take part in an interactive spin the wheel activity to explore how they connect their acute pain experiences with the various domains of social and emotional well-being. These approaches create safe space for stories and experiences to emerge in a very flexible manner. So their influence has been critical to the progression and integrity of this project by ensuring that this research remains grounded in Indigenous priorities, shaped by Indigenous voices, and aligned with Indigenous ways of knowing. Now, although we are yet to commence data collection, the participants have been and will remain the center of this project. So they're not considered as just mere research subjects, but rather co-creators of knowledge. This is because their insights will shape the development of culturally safe and practical recommendations for improving acute pain care in the ED. Although we are yet to develop a final plan, we have brainstormed some ideas for dissemination during our last project reference group meeting. And our intention is to share the outcomes through sessions and posters in community health settings and the ED itself, ensuring that the research is brought back to the people and places from which it emerged. So as my presentation comes to a conclusion, there are a few takeaways I wish to share with you. The journey so far has not been linear, and there are many lessons I have learned along the way. For anyone of non-Indigenous background who has a passion for Indigenous health research, there are three tips I can give you based on my personal journey so far. The first is that relationships are the foundation of Indigenous health research. These will take time to build, but will eventually become the cornerstone of your work. I can say with certainty that the people I've met in this journey have not only been valuable in the progression of this research, but I now consider them as close colleagues and friends. Without that trust and genuine two-way learning, the research becomes simply extractive rather than collaborative. The second is that listening invites stories that questions may miss. When I began this PhD, I went into every conversation with a neatly prepared list of questions, either on paper or in my head, thinking I already knew what I needed to ask. However, I now realize those questions were restrictive rather than opening up space for conversations. So it is vital to take a humble approach to research and realize that some of the most powerful and generous insights you gain may come from simply sitting quietly, being patient, and allowing conversations to unfold naturally. The third is that unlearning is just as important as learning. I found that I had to let go of the comfort and structure and certainty of my previous research approaches, and make room for Indigenous methodologies that were unfamiliar to me. But they were shaped by community time and priorities rather than my own academic timelines. This required me to step back, reflect on my own assumptions, and become comfortable with moving at a different pace, one that honors people. These lessons have changed the way I work, the way I listen, and ultimately the way I understand what meaningful cross-cultural research looks like. And on that note, I'll bring my presentation to a close. Thank you all for your time and for listening so attentively. If you would like to discuss my work in further or have any deep questions, please feel free to contact me. I've given my email and LinkedIn below. Thank you.
So much. Merin, if you wish, you can even copy in a chat. It would be easier for people to copy and paste. And thank you so much. It's not an easy to conduct this research as not Indigenous person, so I really appreciate your work.